USMLE-style question on Sturge-Weber syndrome. Question: a 2-year-old boy is brought to the clinic due to recurrent seizures that began in infancy. His parents report that he also has developmental delay. On physical examination, there is a unilateral, non-blanching, pink to purple macular lesion covering the right forehead and upper eyelid. Ophthalmologic examination reveals elevated intraocular pressure in the right eye. CT scan of the brain shows tram-track calcifications in the right occipital region. Which of the following is the most likely underlying cause of this patient's condition? A. Abnormal neural tube closure. B. Inactivating mutation of NF1 gene. C. Somatic mosaicism of an activating mutation in the GNAQ gene. D. Defective migration of neural crest cells leading to adrenal insufficiency. E. Mutation in the TSC1 or TSC2 gene. Answer C. Somatic mosaicism of an activating mutation in the GNAQ gene. Explanation: this patient has Sturge-Weber syndrome, SWS, a congenital neurocutaneous disorder characterized by port wine stain, nevus flammeus, in the V1-V2 distribution of the trigeminal nerve, seizures due to leptomeningeal angiomas, intellectual disability, glaucoma due to episcleral hemangioma, tram-track, calcifications seen on brain imaging. Pathophysiology: somatic mosaicism of an activating mutation in the GNAQ gene leads to abnormal capillary venous development, resulting in vascular malformations in the skin, brain, and eyes. Neurocutaneous triad: 1. Port wine stain facial capillary malformation present at birth, unilateral, does not regress. 2. Leptomeningeal angiomas lead to seizures, stroke-like episodes, and progressive neurologic decline. 3. Ophthalmic involvement, glaucoma, episcleral hemangioma, can cause vision loss. Diagnosis: CT MRI brain tram-track cortical subcortical calcifications, fundoscopia, episcleral hemangioma. Management: seizure control, antiepileptics, intraocular pressure control, glaucoma management, laser therapy for port wine stain. Why not the other options? A. Abnormal neural tube closure would result in neural tube defects, e.g. spina bifida, anencephaly, not vascular malformations or port wine stain. B. Inactivating mutation of NF1 gene, seen in neurofibromatosis type 1, NF1, which presents with cafeolate spots, neurofibromas, Lisch nodules, optic gliomas, not vascular malformations or seizures from leptomeningeal angiomas. D. Defective migration of neural crest cells leading to adrenal insufficiency, describes congenital adrenal hyperplasia or Hirschsprung disease, which affects the adrenal gland or enteric nervous system, not vascular malformations of the brain and skin. E. Mutation in the TSC1 or TSC2 gene, seen in tuberous sclerosis TS, which presents with hypopigmented macules, ash leaf spots, cortical tubers, subependymal giant cell astrocytomas, cardiac rhabdomyomas, renal angiomyolipomas, and autism, not a port wine stain or tram-track calcifications. Take-home point: Sturge-Weber syndrome, SWS, is caused by somatic mosaicism of an activating mutation in the GNAQ gene, leading to a port wine stain, leptomeningeal angiomas causing seizures and intellectual disability, and glaucoma. Brain imaging shows tram-track calcifications. Would you like another question comparing Sturge-Weber to tuberous sclerosis